This is Advanced Patient Care Theory 2, Unit 3, Part 1, Neonatal Care. All right. There's some interesting changes to the neonatal resuscitation protocol in the 4.4 version of the medical directives. We'll talk about that in the next presentation, though. So, we don't get a lot of pregnant patients in relation to the rest of our call volume. And when we do, we don't do a lot of deliveries, but we need to be sort of mentally prepared to, one, deliver, and two, to resuscitate the newborn, even though these are infrequent occurrences. So about 6% of field deliveries will require some level of life support, either stimulation or positive pressure ventilation. And the incidence of, or the risk of, complications with the need for resuscitation increases as the birth weight decreases. And about 80% of underweight newborns, so that's under 1.5 kilos, require resuscitation. So those are generally under 34 weeks gestation. So some intrapartum factors or risks include premature labor, meconium-stained amniotic fluid, premature rupturing of the membranes, so more than 24 hours prior to delivery, and narcotics within the last 4 hours of delivery. That's not generally an issue with you and me unless the patient has chronic pain and was taking narcotics. And abnormal presentations, prolapsed cord or bleeding. Some antepartum factors include multiple gestations, inadequate prenatal care. Mom is either under the age of 16 or over the age of 35. History of prenatal morbidity or mortality. Post-term gestation. So someone's got an open mic, which is really loud. FYI. And yeah, heroin addicts would be the exception for sure, Chris. Drugs and medication, toxemia, hypertension, diabetes. And so pre-delivery oxygenation, generally considered reasonable when there's any suspicion that it's going to be a complex delivery or there's a compromised fetus. And oxygen will diffuse across the placental membrane for the neonate. Nasal prong is usually fine. Makes it a little easier to communicate with mom in any case. So about 10% of newborns require some assistance in breathing at birth, and only about 1% require extensive resuscitation. One of the most important things, we talked about this before too, is the loss of heat in newborns, particularly preemies, because they lack brown fat for burning to generate heat. And so I think I mentioned to you I was involved in a delivery a couple of summers ago, and it was a hot day, and this was a full-term baby, no complications whatsoever, and we did all the things we thought we were supposed to do and transported the baby to the hospital, and the baby had a temperature of 34 degrees, and the nurse complained to the service, and since then we purchased these aluminum carrying devices that we're supposed to wrap the baby up in, and you can put hot packs on the outside of it, so we avoid hypothermia. But I was surprised. I guess it was that little exposure to the air-conditioned house for that baby that must have dropped the temperature. So this is a chart you may be familiar with, and if you haven't taken the neonatal resuscitation program, I'd encourage you to do that. It's just a one-day hands-on course now because you do the theory component online. And if you guys are interested, we can probably arrange to do a neonate course with John Lee this summer. if that appeals to you guys. I should also mention to you that there's, as a sidebar, in May there is a group of 16 students and 2 faculty from Victoria University in Melbourne, Australia, who are coming to Ontario to visit. They're going to be doing rideouts in Toronto, and I've invited them up here to Georgian College to sit on some lectures. So they may sit in on lectures with you guys on a Monday in the review course. Just FYI. And what else was I going to say? I think that Janine Korb will probably end up teaching that course for you guys this summer because they've got me doing curriculum work. Just FYI. Anyway, this is the inverted triangle that you'll see in the neonatal resuscitation program textbook. And so the first part is to dry and warm the baby. And the critical part about drying is you dry, then you remove those wet towels and you replace it with dry, warm towels. And supplemental O2, not generally required unless they've got generalized cyanosis, not just cyanosis in the hands and feet. And PPV if their heart rate is less than 100, and chest compressions if their heart rate is less than 60 after 30 seconds of PPV. And the medication is last. And the interesting piece about medications is we still have in our directives the administration of epinephrine in a baby who doesn't respond to PPV and chest compressions. But it looks like it's completely absent from the 4.4 directives. So I'm not sure what's going on there, if that's just new evidence that's showing that epinephrine has no benefit in the neonate, or whether they've just arbitrarily decided to pull it. So immediately post-delivery, we're going to warm and dry over about 30 seconds or so. Remove wet towels, replace them with dry ones, and neonates will lose heat very, very rapidly if they're left wrapped in wet towels. So drying also provides as much stimulation as a baby possibly needs, so there's no need to flick the feet or rub the back or anything like that. So we want to wrap the body head to toe to preserve heat and put baby up against mom's chest. So if the baby was born flaccid, we had to position the airway. What are your thoughts about which airway is most appropriate here? Okay, so just looking at answers. And yes, A is the most appropriate head position. Notice with newborns, the occiput is considerably larger in relation to the body compared to adults. And so because the occiput is large, the neck is already flexed, and then we just have to extend the head. This is a neutral position, and the airway may not be patent here, and this is hyperflexed. Now with newborns, you could just put a little towel roll underneath the shoulders. We wouldn't normally do that in adult. We would put a towel roll underneath the head instead of the shoulders, but with newborns, just under the shoulders. That's good. So I think we mentioned this before. We don't routinely suction the airway anymore. It used to be that as soon as the head was delivered, we would suction the mouth and then nose. The mouth first because they're obligate nose breathers, and suctioning the nose first can stimulate aspiration of whatever fluid is in their mouth. But we don't routinely do that anymore unless there's thick meconium obstructing the airway, and then we suction the mouth and the nose and the hypopharynx before delivering the shoulders for stimulation. Now you're probably not going to be able to do, you won't be able to do endotracheal intubation in newborns until they're completely born. So if the baby is born flaccid, then we suction the trachea. And to do that, we use a meconium aspirator. That's what it looks like. So this attaches the 15 millimeter adapter, this to the suction tubing, and this is the port that we occlude with our thumb. And anyone know what the suction should be set for in a neonate? Yeah, negative 60 to negative 100. So yeah, negative 80 would be reasonable. Good. Excellent. And so If significant meconium is present, we're going to suction the hypopharynx. We're going to intubate and suction the trachea using a meconium aspirator. And we're going to suck as much and as quickly as possible. So we're not going to be stimulating the baby. You might just cover the baby with a towel to keep the baby as warm as possible. And we're going to continue until as much of the meconium as possible is clear from the airway, and follow that with positive pressure ventilation. So while you're getting ready for suction, get someone else ready with the PPV and someone else to hook up the monitor. So if the baby doesn't breathe immediately with initial stimulation, they're probably going to need positive pressure ventilation. So we're going to take an apical heart rate, and we're going to hook the baby up to the monitor quickly. One of the things we're looking for is to determine whether the baby is vigorous, and that's defined as good respiratory effort, good muscle tone, and a heart rate of at least 100 beats per minute. If the baby has generalized cyanosis or central cyanosis, so cyanosis not just the hands and the feet but the face as well, then you can provide supplemental O2 for a brief period of time. And these are the values you generally get. So if it's about 2 inches away, you'll get 40%. An inch will give you 60, and a half inch will give you 80% roughly. And if you were to cup the oxygen with your hand, so in other words, draw the tubing up here, then you increase the reservoir. Your hand becomes a bit of a reservoir for the oxygen. That may increase the FiO2 as well. So these are the options for oxygenation: a BVM, a simple mask, or O2 tubing. The APCAR score, I wouldn't memorize the APCAR score. I would just memorize what it stands for, just in case that comes up on a test. But you can get an app now for the APCAR score. I seriously wonder if it's a big priority in a resuscitation when you've got, maybe 4 paramedics on the scene. I mean, if you think of it, great. If not, I wouldn't worry about it a whole lot. So it's not used to determine the need for resuscitation. This is why I debate the value of the APGAR score. It does help quantify the newborn's response to resuscitation, and the way it's done is 1 minute and 5 minutes, and if the score is less than 7, it should be done every 5 minutes for 20 minutes. So we want to continually assess the infant's respirations, heart rate, and what may be different on your slides from mine is I put monitor here because the current HA guidelines recommends maybe an apical heart rate assessment initially with a stethoscope, followed by immediately putting the baby on the monitor and monitoring the heart rate that way. Heart rate and color, and the cycle should be as such, right? We do an evaluation, we make a decision, we take an action, and then we go back and reevaluate entire resuscitation. So that's it for that one. Any questions about neonatal assessment rather? I was going to say resuscitation, but we'll be talking about that next.
I suppose I'm going to wait until you talk about it next, but you mentioned that they removed EPI in the newest NRP?
Yeah, do you guys have a copy of the 4.4 version of the directives?
I will.
I don't think they're going to be implemented till probably early 2019 would be my guess, because there's some, as you guys know, there's some changes coming down the line for December, and probably implement the new directives sometime in the early new year of 2019. Yeah, so I'll post a set on the Advanced Patient Care Theory 2 Blackboard site just so you can have a look at them.
Yeah, so I'm looking at 4.4.
Yeah.
The EPI is still in there in this one.
It's in yours? Because I don't have it in mine.
Well, For whatever reason, they haven't included it in the same flowchart format that they do for all the other drugs. So at
Yeah.
the very bottom, with the heading as long as heart rate is less than 60, it then mentions the epinephrine 0.01 milligrams per kilogram.
Okay, I must have missed that then. My apologies. Let me
I think a
just
lot of us will.
Yes,
Um,
yeah.
let me just have a look here.
yeah, it was a point of curiosity. I don't know why it's tucked in at the bottom and not put out blatantly like it is for everything else in this directive booklet.
Yeah. So it's under the neonatal resuscitation medical directive, correct?
Yeah, yeah.
Okay. So I'm looking at that right now, and I'm just recording this. You guys can't see the page that I'm looking at, but I see. I'm looking at the flow chart, and I don't see it at the bottom of the flow chart. I'm looking
So
at
I'm looking
page
at
35
4.4.
right now. What page are you looking at?
This is page 89 of the PCS
Oh,
4.4 ALS
89.
PCS.
Okay. Maybe I'm looking at the PCP. Maybe that's why. 89.
You're looking at the ALS PCS?
I might have been looking at the PCP. Let's just see here. That might have been my confusion. Okay. Oh, yep, I see it. Okay, yep. You're right. Gotcha. Okay.
Now, what's peculiar is there's no minimum dosing like there is in the medical cardiac arrest for epi.
Yeah.
So, once you go above a certain age, you suddenly have to get the minimum. That's a significant overdose to what it would have been weight-based dosing prior to.
Mm. Yeah. Yeah. Interesting.
Yeah.
Okay. Good. So I see it now, and let's take a break at this point. So hang on a second.